ectopic pregnancy is a surgical emergency.
Hello and welcome back to my YouTube channel, Pick and Rate. If you're new here, karibu sana, and don't forget to subscribe to this YouTube channel because we have fun and cook at the same time. And clearly, we are not in the kitchen. Watu wangu sijawatupa, by the way. Ubeste yenyu alikata ningia kitchen like kabisa. So si ati nimewatupa, but I am honored to take you through my pregnancy journey and of course giving you and educating you about pregnancy. Okay, so my people, you asked for him, and whom's am I? I decided that I am going to bring him here because we had a topic about ectopic pregnancy and most of you didn't understand, and I thought, why not? Why not bring someone? Actually, nilijaribu kukua daktari kidogo. Give me credits, you guys. But today I have a professional doctor who is going to take us through this topic, ectopic pregnancy. Daktari.
I am Zims.
You are Zims. How are you?
Very fine, thank you. Good to see you as usual.
Good to see you too. Salimia hawa watu.
My fans, hamjambo. Yes, keeping safe. God bless you.
Ata wanakujua jina.
Daudi, Dr. Thuo.
Yes. From
consultant obstetrician gynecologist at La Femme Healthcare.
Yes. Umeniambia si La Femme.
Si La Femme, ni La Femme in French.
La Femme Healthcare. That means I think in a sound female.
Yes, it actually means the female.
The female. So I wasn't so wrong. I wasn't so far from that.
From the truth.
Yes. So Dr. The reason why I called you here, we've had a topic going on about ectopic pregnancy. And I tried to educate these people, but you know what? I'm so sure I didn't do my best. But you are here. I talked to you and you saw my story. And you are so good. You said we will talk about it. Hapa Pick and Rate. Tell me, what is an ectopic pregnancy?
So thank you for having me. An ectopic pregnancy, by definition, is a pregnancy that grows anywhere outside of the uterus. So the commonest area is the fallopian tubes. It can grow on the ovaries, it can grow on the intestines, it can grow on the cervix, it can grow on the abdominal wall. So it can attach itself anywhere. If it attaches itself anywhere outside of the uterus, then it's ectopic.
It's an ectopic. Now, what are the causes? Because for the pregnancy, rather for the fertilized egg, right?
Yes.
For it not to attach itself to the uterus, there must be a reason.
Yes. Now, most of the time, so you find fertilization occurs within the fallopian tube. So when it occurs within the fallopian tube, you can find that instead of the small hairs within the tube that actually usher the egg into the side of the uterus, but sometimes then they are either not working well, therefore the egg does not move from where it is. So if it doesn't move from where it is, it grows within where it fertilized, which is within the fallopian tube. Sometimes you find it doing retrograde. Instead of now pushing the egg down into the uterus, it now pushes it outside of the tube, and outside of the tube now you go into the abdomen itself, and now that can be anywhere, all those sites that we mentioned.
Amazing. Now we have signs and symptoms of this ectopic. I was trying to tell guys it's the most painful. I think I've gone through labor pains and of course the ectopic pain, and according to me it is the most painful pain. Kuna kitu kama hiyo? It's the most painful I've ever felt. What are some of the signs and symptoms of an ectopic pregnancy?
Very good. So the first one, of course, is missing your period. So missing the signs and symptoms are just like any other pregnancy. The first one being missing your periods. In the early phases, you have your feeling tired, because a pregnancy is like a parasite, so it's draining you, it's using your resources to grow itself. Thirdly, you can have breast tenderness, because usually the breast glands then start increasing in terms of manufacturing capacity, if you will. You can have effects on the tummy, so you have bloating, constipation. You can have issues like you're peeing frequently. So all the common signs and symptoms of pregnancy. So in the early phases, everyone is excited. Everyone who's anticipating a pregnancy is excited because of those symptoms. A pregnancy test which looks at the effects of the hormones, it looks at the hormones produced by the placenta, will come out positive. Yeah. Just like because it is a pregnancy.
Yeah, it's a pregnancy.
So the issue that comes in that differentiates it from a normal pregnancy, in as far as we've said, there are very many similarities that it has, is the fact that one, there could be excruciating pain on one side or the other of the lower abdomen. Usually, of course, we know the uterus is a mid-lying structure. You can still get such pains in a normal intrauterine pregnancy, but in the time that it goes into the tube, remember, which we said is the commonest area, the tube is a very thin structure. Yeah. So when it is growing and expanding within that space, then this tube, which has some nerves, then is feeling the effects of that excessive stretching. So that can be one of the signs. However, that can be similar to a normal intrauterine pregnancy, which has a cyst, because there are normal cysts you can get during pregnancy. Yeah. And also you can have the uterus, which is holding a normal uterus that's holding a pregnancy can be facing more of one side than the other. So initially you may not know. So the pains can be there. Secondly, can be spotting. So spotting in pregnancy, because within the uterus there is the lining that is there, which has failed to, which is supposed to be there to assist in the pregnancy to come and attach. But now the pregnancy did not attach there, so there can be an element of spotting. Again, in a normal intrauterine pregnancy, there can be spotting sometimes as the placenta is trying to attach itself. The main sign and symptom that differentiates it is when you do the ultrasound scan and you notice that you have a sac and more so a heartbeat or an embryo outside of where it's supposed to be. Very rarely do we have what we refer to as heterotopic pregnancies, whereby you have a pregnancy, one within the uterus and one within the fallopian tube.
Wait, okay. So, okay.
I've thrown you off there.
Yeah, you have thrown me off.
Yes, there are instances that you can have that as a possibility. And yes, it's a bit rare, but it happens.
Rare, but it happens. So how do you usually diagnose?
So diagnosis comes with one, what we refer to as clinical. So clinically, you can have a clinical suspicion that this pregnancy is not going as usual. So it may be because the signs and symptoms, you remember a pregnancy is limited as to how far it can grow when it is outside of the uterus.
Yes.
So the signs and symptoms may be a bit more toned down than usual. So less nausea, less vomiting, less tenderness of the breast, especially for someone who's been pregnant before, would sometimes, and not all the time, sometimes notice that this pregnancy is different. Now that is not a reliable sign and symptom, because all pregnancies are very unique. You can have one with excessive nausea, the other one with less. But clinically, then you're able to then find out that, okay, the pregnancy is not exuding sort of symptoms that are very in keeping with a pregnancy at that stage. Secondly would be what we refer to, so that is actually about clinic, when you listen to a mother and her signs and symptoms, and it comes off that something is off. Secondly comes to doing the physical examination. So physical examination means that now we come in and we are assessing, we're doing the checking of the head to toe, because we do that in pregnancy, and you're assessing to see, do we have tenderness, and we find there's marked tenderness or pain on one part of the abdomen more than the other. There could also be an element of anemia, that this lady looks remarkably anemic, so looks very pale. You could see instances that even what do you call this? The symptoms were very high at some point and then now have suddenly dropped significantly. So all those are telltale signs. So there's the physical, like there's the history, then the physical examination gives you. The third one now comes into doing the laboratory tests. So the lab test now would be a blood pregnancy test where we are looking at the hormones of pregnancy, and you may find that they are lower than what is expected for a pregnancy of a certain stage.
Is that HCG?
That is the HCG.
HCG levels.
Yes.
There are people who didn't understand what HCG levels are. Can you just expound a little bit?
So HCG, or the full word is beta HCG. Beta HCG is a certain hormone produced by the placenta. So the older the pregnancy, you find, especially in the first trimester, it goes increasing exponentially, and that can tell us about the health of a pregnancy. For example, if we are monitoring how a pregnancy is growing week on week, it's supposed to be a hormone that increases at a certain rate. So if it grows up to a certain place and then stops, or it is not multiplying like we would imagine it to be, or as normally it does, then that gives you an indication that all is not very well.
Okay. Let's talk about a ruptured ectopic. You've talked about it growing. The most common place is the fallopian tube, because personally that's where mine was, and it was cut, you know. I was told it was ruptured. So let's talk about a ruptured ectopic.
Okay. So with the last test, we talked about an ultrasound scan, which is now what we refer to as the radiological type of examination, which is an ultrasound. Now, when you assess in the ultrasound, you see that within the uterus is empty, or may have what we refer to as a pseudo sac, which looks like a pregnancy sac but has nothing on the inside. And the sac is usually much smaller than you expect for a pregnancy of that stage. Then on the sides, you would then see a sac and a heartbeat. So if you see a sac and a heartbeat outside of the inner lining of the uterus, then you know that then it becomes an ectopic. Now, you look to see, is there increased amount of fluid around that, around the abdomen. So if fluid accumulates within the abdomen, and fluid includes the blood and etc., then it tends to accumulate behind the uterus, the space between the rectum and the uterus, and we can be able to see an increased amount of fluid. That gives us an indication that we may have some internal bleeding. Then if that fluid is excessive, then it refers to there being probably a ruptured ectopic pregnancy. With rupture, you may find that the pregnancy is still within the tube, or upon rupture, then the pregnancy has also moved outside of the tube itself. So if it is within, for example, the length of the fallopian tube, you can find it towards the end, or what we call the finger-like projections. When it is there, you can find that the pregnancy gets actually pushed out and it falls. So you're only able to confirm that the test is positive, and then when you look for around the uterus, you see a lot of fluid. That tells us you probably then have had a rupture. Other signs and symptoms would be anemia. You find the blood pressure is much lower. So all those are telltale signs about there possibly being a ruptured. On the other side, if the pregnancy is not ruptured, then you could find, in most cases, the heart rate is still present. Secondly, there is no abnormal fluid collection, and we say hemodynamically, which means your blood pressure, your blood level, all looks to be within normal. So nothing has changed.
Amazing. So guys, I hope so far so good, and you unaelewa kitu yenye inaendelea. I am so sure there's someone somewhere who would ask, because I've had ladies who came and said they had ectopic pregnancy, they're still trying to conceive. How long does it take to conceive? Others came and told me they got an ectopic like 7 years ago, they're still trying to conceive. Others came, they got pregnant like almost immediately. Let's talk about, Can you conceive after an ectopic pregnancy, and for how long do you have to wait for you to conceive?
Oh, very good question. Now, being even a fertility specialist, and we go through this quite a lot, because we always try to point out that conceiving is a multifactorial sort of event, which means that you're looking at the semen or the sperm being good, you're looking at the uterus being fine, you're looking at the hormones being intact, you're looking at the fallopian tubes being open, and on top of that, then it's a game of chance, and the chances increase the longer you try, and that you're maximizing on your fertile days. Now, if a lady has had an ectopic pregnancy in the past, and then that pregnancy is resolved either through surgery or through what refer to as conservative methods, then there is hope for the lady, but depending on what other factors are there, what other underlying factors are there. If we talk, for example, that there are multiple fibroids that are obstructing the uterus from occupying that space, the pregnancy from occupying the space within the uterus. If you're talking about issues of hormones being out of sync, then those are other factors that come in. However, if the only issue had been that there was an ectopic pregnancy that happened, and that one tube gets to then be done away with because it was ruptured or damaged to a level that it cannot be repaired, and that the other tube is perfectly intact, then there is no reason why that lady should not be able to conceive again. Yes, and of course we have the poster child right here.
Oh yes, here we are.
Testimony.
This is baby number 2 after the ectopic. So
pregnancy.
Clearly, guys, yes, it's possible for you to conceive after an ectopic pregnancy, as long as the other tube is healthy.
Very good.
Of which your doctor will tell you if it's healthy or not.
True.
Yes. So let's go back. Kidogo, I've jumped something. What are the health risks of an ectopic pregnancy patient?
Very good. So when we talk about the health risk, we have to then work backwards and see what was the cause of the ectopic in the first place. Because now when we talk about causes of ectopic pregnancy, we know that it is a damage to the tube in itself. So is it that the damage was, you can find one, that there was use of medication. So for example, just using like someone being on medication can affect the tubes. There are very many things that can affect the tube. So being on just usual antibiotic, they are painkillers, they are etc. that can have an effect on the fallopian tubes. There can be the more common ones are something like using, for example, P2 is known to have an effect.
The P2, the emergency pill.
The emergency contraceptive pill then is known from studies that confirmed that it has an effect on temporarily paralyzing the small hairs along the tube, which help to push the egg. Illness can cause that as well. Things like radiation, someone has gone through radiation therapy or X-rays, for example, those ones can have an effect on the tube. So there are multiple things that we know and some that are still going through research. There can be an unknown effect on the tube, so by that it comes in just random, that this tube, for some reason, during this time, the pregnancy did not get pushed, the fertilized egg was not pushed down towards the other side. It could just be a very random effect. There could be issues of TB that affect the tube. There could be issues of what do you call this, previous surgeries, that now there was a surgery that tampered with the tubes, or the tubes were attached, and when they're attached they caused a segment of the tubes to not work very well, so that it is not working. It could be something that you are born with. The tube, that particular tube was not the same way you can have any what we call them congenital abnormalities can also affect the tube. There can be alcohol, drug, so there are multiple factors that can affect a tube to not function. Now, based on what the cause is, then informs subsequent conception. Now, do you have, for example, something like your TB, if you're looking at something like your radiotherapy, if you're looking at your previous surgeries that may have tampered, if you're looking at an infection that may have risen from the birth canal and went up and blocked the tubes, which is, most of them are STIs, have those been resolved? Was the damage that they did temporarily, and was it temporary until it was treated, or did it go permanent? So there are various factors really that we look at, and what are the other associated factors? We say that the tubes work in close concert with the sperm, with the uterus, the endometrium, the cervix. We're talking about the hormones, so all those things have to then be in sync. Do you have excessive stress? Because stress, we know the effects of stress are debilitating on the body. We know people who have excessive stress don't want to move. You'll have almost even with depression, you find people do not want to then move. The same thing would happen almost even with the tube, such that if there's psychological stress has effects on the body parts, including what we refer to as psychosomatic illnesses. So there's a lot that can cause, and identifying what the issue is informs what you do in terms of management to resolve that.
Okay. You have mentioned about P2.
Yes.
Nataka tuiguzilie haraka sana. There are people who use P2 as a form of family planning. You are aware?
Yes, I am. Yes, I am.
Is it?
It should not be. So what happens is P2 in itself is supposed to be an emergency contraceptive. Emergency contraceptive means that within 72 hours of a sexual act in which you are high risk for conception, which means was unprotected, then you take this. But it's not supposed to be taken more than once every 3 months, because the effects of it tend to go within your body for 2 to 3 months. So if you take any time closer than 3 months, then you find that 1, it is very likely to fail. 2, you are likely to suffer longer side effects in terms of interruptions within your menstrual cycle. There is, remember we say, these methods, especially that are hormonal, you have to be very sure that your partner is also safe in terms of illnesses, especially STIs, because they protect against only pregnancy but not pregnancy and STIs. So these STIs are the ones you're talking about having a strong effect in leading to tube damage that causes ectopic pregnancy.
Watu wa weekend nyinyi. Oh, nile niko huko. Watu wa weekend nyinyi. Wenye mnaendanga tu mnapigwa vitu huko, alafu you just go running for P2s every weekend. Guy, that thing is not good for your health. It's not a contraceptive. And if you want a contraceptive, a family planning method, tafadhali, we have La Femme. We have Daktari here who is going to take care of that. Daktari, I thought it's important we talk about that because I realized we have people who use that as a method. Na wako tu sawa na life. So, the moment you get an ectopic pregnancy, what are the treatment options that are available?
Very good. So as soon as you confirm that someone has a pregnancy outside the uterus, aka ectopic pregnancy, then one, confirming the size of the pregnancy is important, like how many weeks are we. Confirming whether we still have a heartbeat is important. Then confirming what the other side effects are, what are the effects you have, then is also important in trying to chart what sort of management you're going to take. The easiest management becomes what we refer to as a conservative management. Conservative is where, for example, it's confirmed to be an ectopic pregnancy, but we don't have a heart rate, the pregnancy was very, very small. We do the beta HCG and we monitor just a watch and wait situation where we see that, okay, the hormones are actually dropping. They are not increasing over time, they're just dropping. And you know that over time the body can absorb that pregnancy, which was very early, that even the embryo, you cannot see the baby. The second one now would be what we refer to as a pregnancy, in which, yes, the baby has grown, but because they are in an environment where they're not drawing maximum nutrients, they could not be able to survive. So therefore the embryo is there but without a heart rate. And there's no other damage to any other structures. There's no bleeding internally. You can opt, if safe, and upon the guidance of the doctor, to take conservative methods, including there's medicines that help to now manage fast dividing cells. So that one is one of the methods that we say it's a watch and wait. It has a list of what we refer to as danger signs, that if any of these symptoms were to occur, immediately we go the ultimate management, which is surgical. But if it doesn't, then we go monitoring week on week or every other day how this hormone is coming down, until we are sure that you are no longer pregnant and that your hormones have gotten back to normal and your periods are coming back again, and that there is no higher risk of you getting another ectopic. The third one now becomes if you have an active heart rate, if you have the pregnancy is big, if you have bleeding internally, if you have what we refer to as hemodynamic changes, then that one, it's ectopic pregnancy, is a surgical emergency.
Wow. Which I got the surgical emergency
upon the rupture.
Yeah, because my tube ruptured and I collapsed, and I just had to go for a. They couldn't save it. Yeah, so they just told me that was the only way they could have saved my life.
Yes.
Let's talk about death in ectopic pregnancy. What's the percentage?
Well, now we don't have the, let's say, the actual figures about those for percentages. However, we know that if not attended in a timely fashion, the internal bleeding then can get to a level whereby, of course, you have severe anemia, your heart gives up, and that's how usually most people would get to pass on. Now, what has tried to be done is, of course, even in terms of having the health facilities, we have your technology in terms of ultrasound to be able to then to capture this early. We know that in the past, what the morbidity, which is called major illness, or mortality, which is deaths, the percentage that was there has now greatly reduced by virtue of now knowing about the signs and symptoms. But that said, and why, of course, I appreciate even this one for the platform to be able to then inform people, is that when we're working even in Kenyatta, because we've trained in Kenyatta, a lot of the time then you'd have younger girls who have taken, and it's good that you've addressed also the P2 factor, who've taken, the Twickenham P2, but then fell pregnant. There was a damage to the tubes. It led to an ectopic pregnancy. They were trying to not be pregnant in the first place. Therefore, they knew they have sorted that one out. But then you have all these signs and symptoms, and you're confused about what's going on, and you immediately feel maybe it's my P2 that did not work. Therefore, you go and add more medication or unaenda kuoshwa, because when you're getting internal bleeding, there's pain, you're feeling nauseated because the blood level is going down, and that may feel like pregnancy-related symptoms. So they would come in, having gone through funny places where you're getting like an attempted sort of cleaning of the uterus, or someone has thought. Remember, we said earlier that in an ectopic pregnancy you can have what looks like a pregnancy, or you call it a pseudo sac within the uterus. So someone says, oh, hata ndio hii hapa unaenda kuoshwa. So
pia zinakuwa na pseudo.
Inakuwa na pseudo.
Masaka zina pseudo. Mkifungua masudo accounts pia pregnancy pale inafungua pseudo. So your pseudo sac anaambiwa hii ndio hii mimba, acha tu kuoshe. This is a patient who's bleeding internally, a young girl. At the same time, umegwaruzwa the uterus, so you're bleeding from there. And of course that you're introducing infection, you're doing whatever, and we'd find people coming almost at the last second. And of course there are very many that then will be able to miss, who did not get an opportunity to be rushed to the hospital. Many, as you unfortunately had the experience, would just collapse.
someone has collapsed, so semekana ni madawa, and there are so many that like those ones that go missed out because you never get to make the diagnosis. Just if this person sat in, they got whatever, they collapsed. No, collapse is a common diagnosis. One of them will say for a lady and you're feeling a excessive dizziness, abdominal pain, those are signs and symptoms that are very serious that you need to then go have checked out. And if you are a young, sexually active lady, not even young, any woman in reproductive age, who's sexually active, and you're having some of these symptoms, then it is there's a likelihood of an ectopic pregnancy. So it's good to go checked out.
It's good
get
to
checked out.
So is it possible? Is it okay to advise them? Because I usually advise pregnant ladies, if you get pregnant, just go to hospital as soon as you can.
Yes.
Just to avoid misdiagnosis. The same thing that happened to me. I was misdiagnosed. I know you know this story.
Yes.
And so is it okay to but no,
yes, so
before
it is important. In fact, I think on that point we usually advise that in terms of pregnancy, when you have missed your period, by the same day you missed your period the next month, it is important to come in. By that time, at least within that time, from the time you miss your periods to the same date the next month, when you come in, among the things that we do, even at La Femme, when you come in the first visit in pregnancy, you've confirmed a pregnancy test from home, you have the signs and symptoms, we take you for an ultrasound scan with an aim of looking at where is the pregnancy, how many babies are you carrying, is the pregnancy in the right position, are there danger signs to that pregnancy, do we have the cervix open? So there are all those things that you're looking out for, and because we have technology, why don't you get to take advantage of that? And that happens even outside of this. Like as soon as you get pregnant, the facility that is closest to you, very, very important that someone goes in and just gets a check. Just know the pregnancy is in the right position and you are doing well. Get the necessary advice, and then from there we can be able to now be told how to stagger the visits.
And how often do people miss the doctors miss the ectopic pregnancy?
Now again, clinical acumen. So we have we know that of course our healthcare systems are a bit burdened because of the numbers, not very many etc. But that should not be an excuse that for someone who's attending clinic, then the doctor should then be able to have this at the back of their mind, that these are potential issues that can happen. Therefore, when you're getting to do those ones for the ultrasounds at an early stage, so the idea is to normalize the clinic, the follow-up, and then there are checks that we do at every stage. Among them, that one for the very first one, the first pregnancy. Because imagine if you're saying you're coming in at, let's say, between 6 and 8 weeks. You have an ultrasound, you can't see where the pregnancy is. It already raises an alarm and you start looking for where is that pregnancy. Why don't we have what we are expecting? Is it that your dates are wrong, etc. So the missing happens in a healthcare system that is not keen. If you're in a system or there's keenness and there is, you're thinking potential issues that you want to then knock off, then it is very hard to be missed. Very hard to
be missed. What is the likelihood of having a second ectopic? Because I remember when I got the ectopic, my gyna then told me, the moment you get pregnant, make sure you go to hospital immediately, because you are likely to have another ectopic because you had the first one.
Sure.
How does that work?
Now, again, what we mentioned about potential tube pathologies or illnesses can inform, because they can inform the likelihood of a subsequent one. So if you have tubal damage, as we said, from surgery, from previous infections, then the tubes, the right and the left, are likely to then get affected. Because if an infection, for example, is coming from, for example, an STD, which is one of the more common causes of tubal damage. So an STI rising into the uterus and going into the tubes, then it can cause these tubes to then come in and become constricted or blocked altogether. So it is very likely that it has affected, as we said, it has affected both as opposed to one. Now, whenever you've had a first ectopic, prior to even conceiving again, a pre-conception checkup becomes very important, among which now, if we are worried about the damage of the other tube, then there are tests that we do, including a not very comfortable test called HSG, in which we push a dye into the uterus to see whether the other tube is open. And that is supposed to form part of what was like a routine workup to be able to inform, do you try to conceive again or not? Because we know in pregnancy, especially pregnancy losses are painful and difficult throughout, regardless of whether it is blighted ovum or you have an early demise or you have an ectopic pregnancy. And one of the ways people want to deal with that is, I want to get pregnant soon because nimemaliza hii, I want to replace the pregnancy. And we say that is very counterproductive because you want to be able to first understand what caused the first one, manage that, then get to improve all the factors so that you can conceive better the next time.
You have mentioned blighted ovum. We have ladies who have actually been asking me about that. I don't know if this should be a topic by itself. Is it long enough to be a topic by itself, or is it something we can just mention? Or
no, we can. I think in now that you've mentioned it, so we said an blighted ovum is a pregnancy failure in which the pregnancy either forms everything else. We're talking about the placenta, forms the sac, but does not form the embryo. So the baby fails to form, but everything else about the pregnancy, the sac, the placenta, forms. Or the pregnancy, because again the pregnancy forms, but the embryo either stops growing too very early. Either of those two situations. So it's an issue where the embryo just doesn't form or fails to form, doesn't form or stops growing very early.
So a fertilized egg inaenda kwa uterus, then there's a sac, but
and a positive pregnancy test all the signs and symptoms,
but no pregnancy growing. Do you have specific causes for that, or?
Now there's a hypothesis around it. So it could be a random factor. It could be an egg quality issue, it could be a sperm quality issue.
Oh wow. So guys, blighted ovum.
Yes.
Ovum, yes. Wenye wamekuwa akiuliza about it, at least daktari ameguzilia kidogo. If you want us to talk about this, we will still talk about it. Ama niaje? Yes. Daktari, I was told that I had PID. We honestly tried to explain to these people what PID is. I think pia sisi hatukuelewa vizuri. What is PID? Because ilifika mali nikaambiwa na like 3 doctors, wewe ni mdogo, msichana mdogo, wewe unapata wapi PID? What is PID?
Now, PID stands for pelvic inflammatory disease. So pelvic inflammatory disease means that when the reproductive system gets an infection can come from inside the body, can come from outside the body, but when an infection happens, it leads to now fluid that then that pouch of Douglas, which is between the rectum and the back of the uterus, fluid accumulates there. Now, one of the bigger issues that we get to see is that it is diagnosed on ultrasound. Now, ultrasound showing fluid behind the uterus does not conclude that it's PID. So fluid can be there, as you said, from various reasons. It could be ectopic. It could be you had a cyst that burst and that is the only place fluid can get to accumulate. You can have issues of another inflammatory condition outside of the pelvis. And that's why this one is called PID. Now, what an ultrasound showing fluid behind the uterus should tell you is to go get checked in case it could be infections, in case it could be those ones where the cysts that are broken, etc. So technically what PID then means would be, as you said, the infection that can come in through the birth canal. So it can be anything from contamination, whereby we say there's contamination of the contamination through intercourse, that then the infection can be picked even from around the environment or around the anus, and the bacteria is pushed up and gets to grow within the uterus. Inflammation happens and fluid settles there. Secondly, you can have the PID coming from an STD, the common ones being your gonorrhea, your syphilis, and these infections then cause again that same inflammation, and that inflammatory reaction then fluid settles back there. You could have an internal infection, so there are various causes of that, but then if an ultrasound shows fluid, go get checked to confirm what is the source of that fluid.
So nilikunyisha madawa but in life.
In life.
Yes.
Yeah.
So we have ladies. Ladies who have been asking me what I took for me to conceive. They've been taking medicine, pia wamekuwa kunywa madawa because they want to conceive very fast. Is there anything that they can take?
Now again, the cause determines what we get to do. So usually we're looking at the cause and the underlying condition and tells us what needs to be done. Now there's no one size fits all. And of course usually this happens when a lot, even for people ask about contraceptives. Hi, whoever I'm Nini, what is the best for me? So there's no one size fits all. It requires that walk where you're sitting and walking with a doctor who understands what's going on with you, and then from there we're able to sit down and customize. This one has the less risk, let us go ahead. That is in terms of contraceptives. In terms of medication to help to conceive or to hasten the process, now it depends. Is it a sperm issue? Is it a sperm quality issue? Is it a sperm quantity issue? Is it fibroids? Does this person have underlying conditions, your polycystic ovarian syndrome? Does this person? So it depends. So not everyone needs. Somebody may need something as mild as folic acid. Someone else may need something as much as IUI or IVF to conceive. And these ones are gauged based on what the condition is. So no one size fits all.
Yeah, so ladies, if you are out there and you feel that you have maybe taken long to conceive after an ectopic pregnancy or after a miscarriage, or there's just an issue that you have that you can't conceive, I want to send you to Daktari. Mimi is your daktari. No, I am not going to answer any question about what should I do, what should I take, what should I personally, I didn't take anything, but Dr.Thuo, just like Daktari has said, it's a walk, one step at a time. If you are there and you feel like uko oppressed sana na una feel umetake long sana na una feel you need medical attention, La Femme is here for you. Dr.Thuo is here for you. He is going to walk the walk with you. I promise you that doctor is going to walk with you. Ama?
Yes,
utatembea now. Sindio?
Yes.
Utawambia what to take.
Yes, what to take, what is best for you. So nothing unnecessary, only what suits you for your current condition and situation.
Yes. I am so sure most of you will start asking hapo kwa comments, my charges and all that. This is the number that we are going to drop La Femme's number here. You call and I am so sure you're going to get assistance. The best assistance that you will need. So, Daktari,
yes.
Do you have any parting shots?
So parting shots is that one, there is hope. I think there's hope in infertility. There's hope after miscarriage, and of course we are blessed, of course, to have Rach here, who is a living example, who is testimony that there is hope at the other side. Of course, it's usually very, very painful. It's a very helpless situation. It's a life-threatening situation, as you said, about collapse and the internal bleeding and even losing the ones for the tube. But even after that, there is definitely hope. What it requires is just coming in, getting to understand your current situation. What is your particular unique issue that is causing you to not be able to then get to take baby home, and what we'll do, of course, we promise is to help to work you up and to do the necessary workups to be able to get to understand your condition and manage it the best way possible and the most effectively and cost-effective way possible.
Yes.
Yes.
So guys, we are bringing you this segment all the way from La Femme Healthcare to the healthcare clinic,
Healthcare center.
Healthcare center.
Yes.
We are bringing you this segment all the way from La Femme Healthcare Center. Dr. Thuo has been walking the walk with me during my pregnancy. He is the one who is going to deliver my baby. I am so proud to say that. So if you want a doctor who is going to walk this walk with you, I promise you guys, La Femme, Dr. Thuo and his team is going to hold your hand and you are going to walk this walk together. Make sure that you call that number below. Tafadhali, pigeni hiyo number, you're going to get assistance. Alafu hapa hivi, cost effective. If you are also there and maybe hautaki kushinda ukipiga simu ama still umepiga maybe hajachukuliwa, we have an email address for you down there. Also, they're very fast in replying your messages, so just do an email, a very quick email, and I promise you someone is going to reply to your email. Here at La Femme Healthcare Center, we bring you much love. Sindio? So if this video has been helpful, tafadhali don't forget to leave a comment down below. Guy, yari kizungu daktari inaisha saa zenye tunakuja kumalizia. Yeah, so kama hii video imekuwa helpful, wacha ni switch. Kama hii video imekuwa helpful kwako, tafadhali leave a comment down below and like this video, and we are glad to walk this walk with you. Until next time, guys. Oh, yes, we are not yet done with Dr. Thuo, by the way. I think our next video we are going to have Dr. Thuo back to talk about. He's called the Myth Buster. Hey, nimesikia. Unajua ulipo hiyo jina daktari. Ulipo jina
Myth Buster.
Yes. So guys, until next time, kwaheri from
La Femme Healthcare Center.
Yes.
Yes. Karibuni.
Bye.